We're going to hand it over to Gus now, who's going to be doing our research and progress presentation today. And his study is from the SWORD study that was just presented by Lilia, that Michelle is leading, along with a lot of our other lab mates who are actually on this call today. So we're actively recruiting for that. So I'll hand it over to you, Gus. Gus, before you start with your presentation, just because we have a lot of trainees too from across different levels, if you could just give a little bit more background about where you are and all your things, medical and research-wise, and your background and all of that stuff. Any advice too, you're welcome to give.
Oh Lord, I don't know if advice is, I'm the place to come to for advice, but I'm more than happy to share a little background. So I'll go ahead and share my slides. All right, does this look correct to everyone? See the slides?
Yes.
Awesome. Well, good evening, everyone. My name is Gus White. I am a 5th year MD PhD candidate here at Virginia Commonwealth University, which, if you're unfamiliar with the MD PhD track, that basically means I'm a little over halfway done with medical school and a little over halfway done with my graduate degree. I like to look at things with a glass half full perspective. So that's how I'm framing both of those. But I'm very excited and honored to be speaking with you all today. I've heard tons and tons and tons of great stuff about the Ivy Lab from Dr. Martin, her presentations as well. I think Hannah Shadowin is on the call as well. Hannah and I are in the same program, same cohort, have the same advisor. We do a lot of the same things, just Hannah does them a little bit better, in my opinion. Excited to be here because I've heard such great work that you've done in the past, and by the sounds of what Lilia said, lots of great work on the horizon as well. So just to give a little bit of background about myself and kind of how I got hooked up with this particular project. So I moved to Richmond from Tennessee in 2018 after I finished my undergraduate degree in health economics. I came straight over to VCU to start the MD PhD program. And my PhD is in healthcare policy and research. My advisor is Dr. Andrew Barnes, but in particular, what I'm interested in is a field called tobacco regulatory science. And in particular, interested in how different characteristics, especially of non-cigarette tobacco products, influence their abuse potential and the role that they can play in kind of a harm reduction framework for tobacco use disorder. And so I have an F30 funded dissertation study where I'm looking at the feasibility of what's called a heated tobacco product. So if you can see my cursor, it's this IQOS product right here is what my study is about. And I'm particularly interested in how the flavors of this device, which are believed to emit lower levels of the harmful carcinogens and harmful compounds of tobacco, affect abuse potential and the likelihood that someone might be able to use this product as a substitute or replacement for their cigarettes. So we also do stuff with e-cigarettes. But how I kind of came to be here tonight was Dr. Martin actually gave a presentation to the MD PhD seminar, I guess it was about last October or so. I was just really captivated by the work that you were doing. I thought the research question was very interesting. Most of my experience in substance use disorder was in tobacco use disorder, but was kind of interested in branching out and learning a little bit more about opioid use disorder. So I came up after the presentation, introduced myself, and asked if there was anything I could do to help. And she's like, well, we've got this data hanging around. Maybe you could help us out with that. And so it was a great partnership. So I guess that would be my one piece of advice for you undergrads and early phase trainees is if you find someone that you think does interesting work, go talk to them. It can seem kind of like scary and intimidating on the outset, but 99% of people, especially here at VCU, are very welcoming and accommodating and willing to kind of bring you on board. So put yourself out there. And so that's kind of how I came here today. And then just one thing that my lab has started doing in all of our presentations is kind of the centering statement about kind of who we are and our relationship to kind of the work that we're doing. And so just want to disclose I'm a white, affluent, male, cisgendered student researcher, which means I have a lot to learn. My intent is to improve the lives of people in communities impacted by substance use disorder in a respectful, patient-centric, and evidence-based manner. So with that, that's a little bit about me. Let's talk about the science, which is why we are here today. So just an overview of what we're going to talk about. I'm going to give a little bit of background and background on the connection between sleep and opioid use disorder. I know this group is pretty familiar with those topics and probably even more familiar with the SORT study than I am at this point. So I'll try to be kind of high level so we can dig into the data and have more time for discussion at the end. Then we'll talk about the objectives, the approach that I'm taking in this particular analysis, dig into the results, which I'm hoping to spend the bulk of our time in, and then kind of some conclusions about what we learned from this preliminary analysis, and then kind of how we can apply that going forward. And I'm super excited to hear what thoughts and feedback you all might have on what's been done thus far, what we can do to kind of improve the project going forward. So any questions before we get going? All right. Also, yeah, feel free to interrupt if you have questions throughout. That's my style. I don't like waiting until the end if you have questions. So anyway, I know Dr. Martin knows who these people are because we laughed about this yesterday, but does anyone recognize these two historical figures on the slide before me? Know who they might be? Well, you are looking at the Greek gods of Hypnos and Morpheus. Hypnos is the Greek god of sleep, and Morpheus is the Greek god of dreams. And what you might pick up from that latter name, Morpheus, sounds a lot like what? Morphine. And we can kind of make this historical inference that even dating back as far as the ancient Greeks, and likely even well before that, there was an awareness that opioid use and sleep had some sort of connection. Now, fortunately, throughout time, we've learned a little bit more about exactly what that connection is. So there's plenty of evidence that acute intoxication and use of opioids can disrupt sleep architecture. Although we typically think of opioids as having a sedating effect. Sedating doesn't necessarily mean restful sleep, and there's plenty of evidence to show that it decreases time to like the REM phase of sleep, which is when you're getting most of your restful periods. And so lots of evidence to show that the opioid to sleep pattern or arrow of directionality is strong. And also the same holds true for withdrawal from opioids also affects sleep. What we're beginning to appreciate now more so is that this relationship probably is actually more bidirectional. And that sleep itself can impact opioid use disorder outcomes in terms of treatment. It also could potentially influence the propensity that one has to engage in substance use disorder later in life. There's a lot of cool, compelling evidence about how teens and adolescents that have sleep disturbances early in life are more prone to go on and to develop substance use disorders later in adulthood. And so we know that poor sleep is a prevalent problem in opioid use disorder populations, and this can persist even once they begin treatment. I think the overall prevalence of insomnia in the general population is about 20%. When you look at OUD populations, that number jumps up to closer to 40%. And most importantly, sleep can actually influence opioid use disorder treatment outcomes. It's not some inane or inert association. It can be really important to the success someone has when they enter treatment. And so this diagram that we have over here to the right is from Eckert et al. And I've just kind of modified it a touch, added these like kind of bidirectionality arrows, which they would agree with, but that wasn't the focus of this particular graphic. But what I want to point out is we're looking at how sleep deficiency can potentially be connected to opioid use disorder outcomes. And so, kind of two large categories of mechanisms that have been proposed are that one, sleep deficiency can kind of have these neuropsychiatric mechanisms. In particular, increased sensitivity to pain has been thought of. Those who have poor sleep quality, more sensitive to pain, thus would be more likely to use opioids. But there's this other branch that we can think of called the neurocognitive mechanisms. Basically, the way that the brain works, processes information, and makes decisions can be impacted by the quality of sleep you receive, and then that resultantly can influence opioid use disorder and substance use disorder in general. And so one way I kind of like to think about this connection right here, in particular from sleep deficiency to the neurocognitive mechanisms. So something we call the competing neurobehavioral decision theory, which we use a lot in my work. And so what this theory essentially argues is that behavior, any behavior whatsoever, doesn't have to be substance use specific, but in this context, we can generalize to opioid use disorder, but it's the result of the balance between two of these neuro circuitry systems, this impulsive system, which corresponds to the paralimbic system, which is kind of lit up in red here, and this executive system, which is lit up in blue. And it's the balance between those that creates behavior. And so in the context of substance use disorder, we can imagine something like sleep that introduces imbalance to these two systems by, for instance, increasing the activity of this impulsive system or decreasing the activity of this executive functioning system, which is kind of meant to put a check on impulsive behavior. That would potentially lead to different trajectories of substance use outcomes. And so we can measure this kind of model in a couple different ways. You know, the original methodology, it seemed like kind of substantiate this, was using functional MRI technology, really actually looking at brain activity at these different localities and kind of correlating them to behavior. But fMRIs are A, hard to do, and B, super expensive. And so another way that we can index them is through these kind of validated neurocognitive assessments, which is going to be kind of the focus of this presentation today. So we know a lot about sleep. We've learned a lot, but there's a lot more we don't know. And that's particularly evident. I think the NIH gave up over $25 million worth of grants in the last like 2 or 3 years, specifically to understand the connection better between sleep and substance use disorders. And so in this particular set of analyses, we're primarily interested in this first question, you know, what are the mechanisms by which sleep deficiency may contribute to opioid use disorder? But in kind of reading the literature, there's a lot of different questions you could dive into. So, you know, junior students in the lab, these are all things to kind of think about, and maybe you can think of a project to kind of tackle. But, you know, does the association between sleep and opioid use disorder differ at different stages and across different treatment modalities? You know, that was a discussion a little bit in your last meeting. Are all sleep dysregulations the same with respect to their impact on opioid use disorder, or is there something different between like hypersomnia and insomnia? Does gender influence the association? And you know, this question in particular is interesting to me. Is sleep itself the proper target in this population? Sorry, we have a new member of the call today. I have a picture of him at the end of the slide, and it was going to be like the big reveal, but nah, he's just here now. But anyway, is sleep itself the proper target in this population, or the sequelae of poor sleep what we should be focusing on? But all of this to say is that it's important to really understand sleep deficiencies, in particular insomnia, because if we can better understand how they impact opioid use disorder, that could be really beneficial in kind of creating these individualized therapeutic treatment plans that patients with these comorbidities say that they need and want. So the objectives of the Project SORT in general are to kind of explore the underlying mechanisms of how sleep affects OUD treatment, in particular amongst women. But what we're going to be doing in these analyses is investigating differences between women who are receiving buprenorphine for OUD treatment. And we're going to kind of segment that into those who do and do not experience symptoms of insomnia, and correlate those to 5 neurofunctional domains, which have been established in prior literature as being important to addictive behavior. So this is the brief kind of study design for Project SORT. I won't belabor this, but the inclusion criteria, where we're looking at 18 to 65-year-old individuals with an opioid use disorder diagnosis who had been stabilized on buprenorphine or had been receiving buprenorphine for at least 6 weeks, and excluded females who are pregnant, those with severe psychiatric impairment or a language barrier that would get in the way of their participation. And in this particular sample that I'll be presenting today, we only have women represented. My understanding is that the project is now open to men as well. Not presenting any data on men, but hoping to incorporate that. We can talk about that later. But that was our population. recruited patients at Motivate and OB Motivate with a goal in of around 100. And then all of those individuals participated in a cross-sectional survey. So there were two parts to it. One was getting basic information about their demographic background, substance use history, sleep history, just kind of those correlates that we'll be interested to look at. And then part two is this phenotyping assessment battery, the light version of it. We'll talk a little bit more about what that means. But participants could complete this either in the clinic or remotely, and they're compensated $15. And then a subset, I think about 12 is the goal, were invited to complete semi-structured interviews, which I believe you all heard about at your last meeting, to kind of delve more deeply into these topics. I have that grayed out because I'm not going to be presenting any data from that. But if you wanted to kind of put the study design for what I'm going to be presenting today on a bumper sticker, I would call it a mixed methods cross-sectional feasibility study conducted amongst a convenient sample of women receiving MOUD. So let's talk about our constructs. So our primary kind of determinant of a sleep deficiency will be this insomnia severity index. And so I have the questionnaire here on the right. And basically the way it works, very simple. There's 7 questions, and then participants rate their current, in other words, their last 2 weeks severity of the following symptoms. So difficulty staying asleep. If they don't have any issues with that, they say 0. If it's been very severe, they say 4. They go through, answer all these questions, and then you get a sum. And so the scores can range from a possible of 0 to 28. Those with the scores of 0 to 7 are determined to have no clinically significant insomnia. 8 to 14 are subthreshold insomnia. 15 to 21, moderate severity, and 22 or greater is severe insomnia symptoms. Importantly, this is not a diagnostic test. This is a screening tool to detect insomnia symptoms. And we're kind of looking at both the daytime and nighttime symptoms of insomnia. Yeah. All right, so that's the sleep. So what are these neurofunction measures that we're going to be looking at, these different domains? So what you have here on the left is the phenotyping assessment battery, which was developed by NIDA a number of years ago. And the idea is that there are all these different phenotypes for addiction. There's not one type of individual who can develop a substance use disorder. And so when we're trying to understand why some people have better outcomes than others, it would be helpful to really be able to understand at a neurofunctional level how different groups might differ. Is it, people with, a certain phenotypic profile have better outcomes than others? And if so, that could inform potential targets. And so that was the idea behind developing this phenotyping assessment. And it captures 6 kind of neurofunctional domains. The first one being cognition, the second one being reward, the third is negative emotionality, the fourth is interoception, the fifth is metacognition, and the 6th is sleep. And I'll go through kind of what all of these mean when I get to the results that they correspond to. But as you can see, there's a lot of measures in the FAB, and it takes a really long time to complete. Yeah, I think what I saw was 83 minutes was kind of the average completion time. And so, that's fine for some settings, but can be very difficult to be feasible in others. And so I think Dr. Martin and other investigators here at VCU, I think, have done a lot of work in kind of scaling down the parameters from the FAB into this FAB light, to kind of get the bare bones isn't the right word, but how can we package this in a more palatable form for participants so that it can be used more widely, rather than just in a very specific clinical context or clinical trial context. And so all of the same domains are represented in the FAB light as in the FAB. Basically, all we're doing is kind of cutting out a few of the specifically behavioral tasks, and focusing more on the self-report measures. So in cognition, we're going to be talking about something called the 5-trial adjusted delayed discounting task, which we actually use a lot in my lab over in tobacco world. And that was kind of what initially excited me about this work. So talk about that. And reward, we'll be looking at the scale that kind of measures impulsivity and negative emotionality. We'll be looking at depression, anxiety, distress tolerance, aggression, those sorts of things. And then interoception, we're kind of interested in how people perceive internal stimuli from themselves and how that correlates to behavior. And then in metacognition, we have this 30-question metacognition questionnaire. And that's kind of about your thinking about your thinking, or your awareness of one's own thoughts. And so you can do this assessment much faster than the FAB. So that everyone in the study did this FAB-like assessment. That was kind of the neurofunction measure here. All right. And then a couple other things that I thought were interesting to look at, and just kind of that next step. So that we have this connection between, sleep and neurofunction is going to be the main focus here. But I did want to speak a little bit, at least, to the connection between like neurofunction, sleep, and opioid use disorder treatment outcomes. And so there's kind of 3 variables that I thought were interesting to look at. 2 of them are very similar. We asked participants, to what extent do you consider your sleep problems to interfere, or in this question, interfere with your opioid use disorder treatment and recovery, and how much would sleeping well help your opioid use disorder treatment and recovery? And those are rated on scales of 0 to 4. And then the third outcome that I wanted to look at is cravings. And so this is scaled on a 0 to 100 visual analog scale. Since yesterday, how much have you wanted to use opioids? We asked participants, because there's evidence to suggest that those with poor sleep quality have increased cravings for their substance of abuse. And then lastly, we also observed some demographic and other covariates, such as age, race, Hispanic ethnicity, educational attainment, and employment status. So analytic approach, just very briefly, the particular sample that I'm drawing upon, the sample size was 52. I think the last time I pulled data was back in like November or so. So I expect the sample size might be a little bit larger now. I haven't updated the analyses since then, so I'm kind of waiting until we get basically to the end. I don't want to over preview results to myself. But I dichotomized the sample based on their insomnia severity index score. So we have 26 participants in the none to mild insomnia symptoms, and 26 in the moderate to severe insomnia symptom categories. And so we're going to be looking at differences between those 2 groups. And I calculated scales and subscale scores for everyone, as well as outcome variables where relevant. And so we're going to be comparing these 2 groups using bivariate statistics. For categorical variables, I just picked chi-square test, as it's a simple non-parametric test. And for continuous variables, we're going to be using a t-test. I also looked at some other parameterizations, and we can talk about whether that's the appropriate test or not. But alpha was set to 0.1, and I'm a big Stata fan. It's my programming language of choice, so that's what we used. All right, we'll look at the data. So this is just the distribution of the insomnia scores. You can see kind of this top row right here, the mean insomnia severity index. Again, the scale here is from 0 to 28. The mean score was 13.6, so kind of on average, very average insomnia symptoms, kind of right down the middle. Obviously, we'll have a difference between the clinical insomnia and the no clinical insomnia group, just based on the definition of those 2 groups. But I wanted to present all this to show that, I kind of had this decision about, do I include the ISI category kind of directly, like those 4 categories, or do I dichotomize that? And there's some potential data loss when you dichotomize and collapse. And I just wanted to show this. The reason I did that is because like the subthreshold and severe insomnia groups are kind of small. And so in order to preserve comparisons across groups and kind of aid the statistical power, I collapsed a little bit, but kind of looking at a sensitivity analysis, it didn't really affect results all that much. But so here's the demographics table. All you really need to take away here is that the 2 groups didn't really differ with respect to age, race, ethnicity, educational attainment, or employment status. Average age here was about 35 years old in the sample. Another kind of important note is this is a pretty diverse sample too. Only about 56% of the participants identified as white, which means 44% in total identified as non-white, which I think is important. And a plurality, it looks like, have a high school diploma as their highest form of education, and most are also unemployed, which is pretty consistent with what we would expect in this particular patient population. All right, so let's look at the neurofunction measures. So this first neurofunctional domain we're going to be looking at is the reward domain. And the particular index that we use in the FabLite to look at reward is this short UPPSP impulsive behavior scale. Actually, I couldn't find what that acronym stood for. I spent way too long looking for it. But basically, this index is kind of impulsive behavior, or the incentive and salience and motivational desires associated with a given substance. And so what you can see here, I've kind of highlighted the significant results in red. So in general, there's, we didn't see a lot of separation in these subscales for impulsivity and reward between the two groups. But we do note that in the negative urgency subscale, that those with insomnia versus those without insomnia reported higher levels of negative urgency. And so what is negative urgency? What does that mean? Negative urgency is defined as the tendency to act rashly when one is distressed. It's characterized by high levels of neuroticism, low conscientiousness, and low agreeableness. And some of the questions we kind of look at in this particular scale are, when I'm upset, I often act without thinking. In the heat of an argument, I will often say things that I later regret. I often make matters worse because I act without thinking when I'm upset. And so we could see how that might correlate to substance use disorders, particularly among people that are receiving treatment. When they experience an emotional insult or distress, if they're in kind of a high negative affect state, they might tend to want to seek out substances to use. This next domain is cognition. And so we're looking at what's known as the 5-trial adjusted delayed discounting task. And this is kind of difficult to explain, so I'm just going to try to show it to you if I can. Come on. Sorry. All right. Can y'all see? You can't see that screen. Let's share this one. Oh, now I've lost you completely. Hang on. This is a really cool software and task, but it doesn't work exactly how I want it to all the time.
This is why we can't do the real task remotely, because of technical issues like this. If our patients ran into something like this, they just stopped the whole study.
Yeah, no, I don't. Not surprised.
Yeah.
I would as well. Okay, let's take it from the top. Okay, can you see the task screen now? So essentially the way this task works is you'll be making choices between receiving $5 now and $10 at some point in the future. It takes less than a minute to play, so I'll just kind of demonstrate it for you. So this first question, you kind of think to yourself, how would you answer this? Would you rather receive $5 now or $10 in 3 weeks? I know personally for me, I'd rather have $5 now. So now it's going to ask me another question. Would I rather have $5 now or $10 in 1 day? Well, okay, I might be willing to wait a day to get twice that amount of money. So I'll click this. And again, this will just repeat a few times. And based on the answers that I'm putting in, it kind of varies that delay they have in the $10 reward. And from that, we can generate what's known as a discount rate, which is basically the degree to which people discount larger delay rewards in place of the ability to obtain more immediate, smaller rewards. See if I can get back to my slides. Okay. Can you all see slides again?
Yes.
Okay, current slide. So discount rate is the direct recovery from this task. It didn't really differ between groups. It's gonna be kind of hard to interpret because it's a unitless measure. So one transformation we can make is take 1 divided by K, and that gets something called the effective delay 50, which turns it back into days. So this is basically the time in days that it takes for a reward to lose 50% of its subjective value. And so, we can see the point estimates are really different between these two groups, although they didn't differ significantly because there was a lot of variability. It looks like a big difference. It's really not, because this is like a super nonlinear scale. So just kind of keep that in mind. I'll also note that there were some issues with the implementation of this task. So when I demonstrated that to you, I only answered 5 questions. There's actually 31 questions kind of operating in the background, but you're kind of forking down a path of this like hierarchical tree, so you shouldn't see them all. I think the way it was coded in the survey, patients actually saw all 31 tasks. And so we've actually corresponded with the group that originally published this task about trying to find some workarounds there, and still working on that. And one other thing I did want to note just real quickly is that this is discounting of monetary rewards. There are other forms of discounting too, and in particular, discounting of effort instead of money has been shown to correlate actually more closely with sleep deficiencies than monetary. So that can be one thing we can talk about later. Just kind of moving on, interoception, again, not a lot of differences between groups here, except in this kind of noticing subscale. And so this refers to awareness of uncomfortable, comfortable, or neutral body sensations, which makes a lot of sense when we talked about pain sensitivity potentially being a pathway through which sleep deficiency leads to opioid use disorder outcomes. And so, all right, we can dig in. We got a lot more red on these next 2 slides. So this is negative emotionality. And what you can see here is that relative to the group that didn't really have any significant insomnia symptoms, those with insomnia symptoms scored higher on measures of depression, generalized anxiety disorder, as well as post-traumatic stress disorder. So I know there was I think a conversation about traumatic stress in your meeting last month too, and kind of correlating that from the focus groups. A lot of people talked about stress being a trigger, traumatic stress in particular being a trigger for substance use. So we kind of see that borne out here as well. Unsurprisingly, because of those 3, we also see differences in global mental health. Again, higher scores here indicate worse mental health on this particular scale. And the last one I kind of really wanted to point out is that distress tolerance, higher scores here, again, to someone who is more stress intolerant. So that relates back well to what we saw in the impulsivity scale, is that, those that experience symptoms of insomnia when they're confronted with a stressor might be more likely to act in what they act discordant with what they would want to do in a normal situation. All right, and so our last kind of scale is this metacognition scale. And so we see overall kind of the total scale score differed between those with insomnia and without insomnia. Again, higher scores are worse in this particular scale. And if we kind of dig into the subscales, we see that, lack of confidence in one's thinking and thought process, as well as having negative beliefs about their ability to control things when they get out of hand, were much higher among the group with insomnia relative to those without. And just kind of this last result slide, we wanted to look at comparing the 2 groups. Those with insomnia relative to those without insomnia were much more likely to say that sleep was interfering with their opioid use disorder treatment outcomes, and B, that improving their sleep would help and be a significant aid to their recovery. We didn't see any differences in craving intensity. I would argue that's largely because these are pretty small. This is a 0 to 100 scale. Mean scores are 7 and 5 roughly. This is a treatment population on buprenorphine, so we would expect to see pretty low cravings because that's a pretty significant target of that treatment. But still, it's not statistically significant, but we do see a little bit of separation there. All right, so what are kind of some conclusions and takeaways? In my kind of read of the data thus far, this sample of women receiving medication-assisted treatment for opioid use disorder, the neurofunctional profiles, in particular with respect to metacognition and negative emotionality, did tend to differ between those who experienced the symptoms of insomnia and those that didn't. And these kind of map directly onto those executive function systems that we saw in the competing neurobehavioral decision system theory, such that kind of the cognitive resources needed to put checks on the kind of impulsive behavior are diminished in those with poor sleep quality. Noted only minor differences in cognition, reward, or interoception. I want to be cautious not to overinterpret that though. A, we're probably underpowered to detect differences. And B, we cut from that large set of tasks and measures in the FAB, the smaller set in the FAB Lite. It's possible that we might be missing some constructs from there that could be relevant. We kind of talked about with cognition, like effort versus monetary discounting might be a difference there. Another takeaway is that patients in the sample really kind of reported that, especially those with insomnia, sleep was a problem and they wanted help with their sleep, and they thought that would be an aid to their substance use recovery. And this kind of just further supports that sleep disturbances are a common problem for those with in MOUD population. So again, if you want to put it on a bumper sticker, treatment of comorbid sleep disturbances and their neurofunctional sequelae may be a full target to improve opioid use disorder treatment trajectories. Quick limitations, obviously, we don't have an objective or clinical diagnosis of a sleep disorder. The Insomnia Severity Index is a screening tool. So results could differ if we use the different measure of sleep dysfunction. Cross-sectional study, purely associational. We can't establish any causation here. It's also a convenient sample, so we need to be careful about overgeneralizing these findings to other populations. Lastly, the two kind of more important issues, don't account for any kind of confounders yet, but that's kind of my goal with the next steps of this project that we can talk about. And like I mentioned, there are some issues with that 5 trial discounting task. So to the extent that it's actually measuring what we're hoping, maybe not. But I think we actually do okay there. But so future directions, this work has been submitted to CPDD and ASIM. Well, hopefully it will be submitted to ASIM in a few hours. And so my kind of next steps and ideas, we're planning to build these multivariable regression models to account for some of these confounders, and or use propensity score matching, which is a technique we use in our lab a little bit. I think we're adding males to the sample now, so we'll be able to stratify analyses and maybe look and see if gender is moderating any of these relationships, which I think is important. And I definitely want to do some more sensitivity analyses about where exactly we're drawing kind of cutoff lines and some modeling decisions. So some ideas for future studies, just about reparameterizing how we think about discounting, adopting a longitudinal time course to chart how variations in sleep correspond to variations in neurofunction at different points in the OUD time course. And then I think the ultimate payoff of this project is to look at whether an intervention like cognitive behavioral therapy targeted to insomnia can actually translate to improved neurofunction in this population, and whether that improved neurofunction might lead to actually changes in OUD treatment outcomes. So probably went a little long. Here are my references. As promised, here's my dog, Sheriff, who's conveniently in my lap at approximately 100 degrees right now. But I thank you for your time and attention. And hopefully that was informative. I'm happy to take any questions, comments that folks have.
Thank you so much, Gus. That was great. It was a great overview of the data and probably the best explanation I've ever heard of delayed discounting. So strong work and making it understandable, because I still struggle with that sometimes as a newbie in the neurocognition world. So yeah, that was wonderful. So I'll open it up if anyone has any clarifying questions. You're not the only one who's thinking it. Those things are helpful for Gus to know, like, oh gosh, maybe I need to explain this a little differently when we write it up, or when we present it at the conference, or anything in particular that you found really intriguing. That's also very helpful, even if it's just a comment, because that also will help Gus figure out, gosh, what can I maybe focus on, maybe for more of a clinical versus research audience. Kind of, he submitted to 2 different conferences, for example, that are both like that. So yeah, I'll open it up if anyone has any questions or comments.
I do. It was a great presentation, very, very informative. So I work with Dr. Martin at the OB Motivate Clinic, so I'm always thinking about pregnancy and the postpartum period. So it's interesting to see the effect of sleep on opiate use, because even if I have my dog here, so even if Our patients don't actually have insomnia. They are still having interrupted sleep frequently. Pregnancy has a lot of sleep disruption, as does having a baby.
Yeah.
So they could have the same sleep patterns as insomnia of difficulty falling asleep, frequently waking up, not having enough REM cycles. So this could have an impact, or, shed some light on maybe why that first year postpartum with all those sleep disruption is so important to focus on sleep as well, even if you don't have the diagnosis of insomnia.
Yeah, that's a really good point, and kind of ties back into, this is a screening tool, so it's not, perfectly specific to insomnia. I think you're exactly right. There are a lot of, time periods in people's lives that would mimic the sleep patterns we see in insomnia, but they might not meet the definition, the DSM diagnosis for insomnia. Those individuals still could be at risk for a lot of these adverse outcomes that we talked about today. So I think that's a really good point, and probably worthwhile to include in the discussion to kind of broaden the potential reach and scope of this work. So thank you. It's a great point.
In relation to that, also, hi Gus, it's good to see you. I didn't know you were presenting, but do you think that there is a difference between like insomnia, the disorder, and interruptions in sleep due to like a baby or other things? Like, do you think that the pathways would be similar, or do you think it would be operating under different kind of pathways or mechanisms?
Yes, I think that's a fantastic question. Again, I'm sort of very new to this literature. I don't want to say sort of. I'm new to this literature, so still trying to learn. I have read a little bit though about chronic sleep deficiency can actually cause rewiring of these different areas of the brain that I talked about in kind of the executive versus impulsive system, to an extent that acute sleep deficiencies don't necessarily mimic. So they've done like experimental studies where they bring people into a hospital and then they like keep them up for 48 hours. So they're like really, really sleep deprived in an acute manner. They put them through these tasks, and their performance on things like the 5-trial adjusted delayed discounting test differ from a population that has kind of a chronic sleep deficiency, like someone who's been suffering from insomnia for 20 plus years. So I think it's, probably not a direct comparison between, or you can't directly map acute and chronic sleep deficiencies onto each other. It seems like, particularly with respect to, long-term patterns of behavior and one's potential exposure to risk for relapsing in the context of like opioid use disorder treatment, I would be probably a little bit more concerned about those with more chronic sleep deficiencies than acute, but that's not to dismiss the potential contributions of acute sleep deficiency. Does that answer your question?
Yeah, it does. Thank you.
Yeah.
Hi, Gus. We met yesterday in clinic. Thank
Yeah.
you for the presentation. It was extremely interesting, and like everybody is already saying, this I think extremely beneficial to our patient population, but I'm sure for others as well, because like you're saying, sleep deficiency is going to impact so many aspects of the way a person manages their daily interpersonal as well as professional lives, their thinking, capabilities and so forth. I was kind of also wondering, because you said you were doing a couple of interviews with patients, right? And I know you weren't going to talk, or were those done yet?
I think those were done by Michelle, if I'm not 100% mistaken. Michelle, if you're on the call.
Michelle had to drop off.
Oh,
So
no.
I think
Well, you might know. I was just kind of wondering I loved, again, like I would have had no idea what that discounting screen tool was if you hadn't shown us. So thank you for doing that. And thank you for your explanation. My first thought was, well, if you're one of my patients, you're never going to trust that you're going to get anything later. So you're going to take it now.
Point.
Oh, it's a sure thing. It's a trust. Like, how many times have people said tomorrow to them in their lives, and tomorrow doesn't, that means no, basically that's not happening. And so I kind of was wondering if that somehow is taken into account. But it sounds like you're already looking at different ways to measure that anyways, besides like, here's the thing, you want this little thing today or this, I don't know.
Yeah, it's a great question, and I would never have thought about like that particular interpretation of the question. So it's really helpful that you share. One response that I'll give is kind of partially addresses that. Is they've done this task. Basically, the way it's administered here is purely hypothetical. So people aren't getting any money based on their responses. In my lab, when we do this task, we actually give people the money that they earned. It's usually like a random draw of like one of the choices that they make. And encouragingly, what we find is that reinforced task versus hypothetical task, responses don't tend to differ between the two. So when a general population of study participants kind of comes through a task, it seems as if they're not like really discriminating about like, maybe I won't get paid, maybe I won't, and like altering their behavior. But that might not be the case in this particular population because they might have a different and divergent set of life experiences. I think what you described could make a lot of sense when you're kind of more focused on, what do I need to get through today? And it's hard to think about, depriving myself of something I need to get through today so that I can, have a little bit more tomorrow or at some point in the distant future. And so if those are the kind of decisions they're making on an everyday basis, when they come to do a task like this, it wouldn't be surprising to me that they have a bias towards that kind of smaller, more immediate reward. So yeah, it's a really good point. I'll just elaborate a little bit more about the other way to kind of think about this. So another kind of method of assessing a discounting rate is called, it's basically we're looking at work discounting. And so we do this in my lab a little bit. Basically, we have people do some task in the lab, some very like menial, repetitive task. Like we have them like press a space bar. And so we use we bring in a cigarette or nicotine deprived individuals into our lab, and we're like, all right, if you want a puff of your cigarette right now, hit the space bar 5 times. Pretty much everyone does that. Doesn't take a lot. But for every subsequent puff they want, that number gets progressively bigger, and we increase it at an exponential rate. So, after 4 or 5 puffs, if you want that 6th puff, you're going to have to sit there and press that space bar over 400 times. And so that's another way of kind of measuring like a discount, like they're kind of discounting the effort that it takes me to actually work up to that puff compared to the reward of getting that puff in the future. And so that's another way to look at it. And the evidence suggests that kind of effortful discounting corresponds a little more closely with sleep deprivation states than monetary discounting does, which I think conceptually makes sense. I know when I'm tired, my willingness to expend effort decreases a lot more than my financial frugalness.
Absolutely.
Yeah.
Thank you.
Yeah, thank you.
Hi, Gus. I'm an M1 at VCU. Just wanted to say, awesome presentation.
Thank you.
Question for you. Do you think the buprenorphine could be having side effects that are affecting sleep in your patients in this study?
Excellent question. So the little bit of literature I have read on this topic actually delves into this a little bit. So buprenorphine, I don't know if you've covered it in your M1 classes yet, but it's a partial agonist of the mu opioid receptor. So someone who's taking heroin, that's a full agonist. Our idea is that we withdraw them off of the full agonist and then replace with this partial agonist. And so that kind of mitigates some of the cravings. But with that partial agonist activity, you're still getting the stimulation of that mu opioid receptor, and that receptor and its downstream effects are part of what we think causes the sleep disruption that we see among people that are using heroin, oxycodone, illicit drug use. And so, another interesting way to kind of look at this question is the differences between those on buprenorphine and those on methadone. So both we're using to kind of maintain patients. Methadone is a full agonist of the opioid receptor. Buprenorphine is a partial agonist. And if you kind of look at the data about like sleep quality over like treatment trajectories, my understanding is that both of them kind of contribute to sleep disturbances, maybe to a lesser degree than using illicitly, although there's some confounding there. But eventually tolerance actually develops to that sleep disruption effect. And I think people tend to recover a little bit better off of buprenorphine than they do off of methadone with respect to their sleep after being stabilized for a period of time. So importantly, in this population, we're looking at those that had been receiving bup for 6 weeks. So the idea, I think, is that they're probably pretty close to what their baseline would be. It's a very meandering answer to kind of get all the way around, but you know, when that comes up in pharmacology in a few weeks, you'll know what the mu opioid receptor is and be ahead of the game. So that's one flashcard I saved you from.
Thank you. Thank you.
Yeah.
These are all great comments and questions. Thank you, everyone. I was really, Margie, your comment was so profound, like, because the delayed discounting task has been used for years in the addiction world, years and years and years. And I don't think I've ever seen someone comment on that before, just because of the trauma histories that our patients have and the high social needs that they have, you know, in that immediate time frame really are so prevalent in this patient population. But this is like probably one of the most like widely used neurocognitive tasks, you know, in this world of research. So I think it's a great point. It might be, I don't know, Gus, if you know the literature at all in this area, but that just made me think if anyone's looked at impulsivity differences by social determinants of health, for example, like if people who have more of those like immediate needs, kind of how Kaylee, our social worker who spoke up earlier, we had to talk yesterday and she was talking about, you know, the hierarchy of needs, right? So her job is, you know, when I do an assessment, what immediate needs does our patient need right now? Because if they don't have their immediate needs met, they can't move on to the next level to focus on their treatment recovery, et cetera. Yeah. So I'm just curious if anyone's thought about that before. Gosh, maybe what does the role of having high immediate needs for basic things like shelter, food, et cetera, how does that impact someone, the measurements, you know, that we're using to guide a lot of these treatments and studies?
Yeah, that's a really good question. I'm not familiar with any literature kind of looking at that topic. I'm thinking about the data we have available, and I know we've collected some data on like social determinants of health. Like I think food and housing insecurity are some of the measures in the SORT study. I don't know, I might just take a peek at seeing at how, in a very like exploratory way, seeing how like discounting differed. I could think of a pretty cool like little pilot study kind of trialing a suite of these like discounting tasks across populations, kind of like you mentioned, but I'm not familiar with anyone that's empirically looked at that question before. I know there is some work, kind of theoretical work. Roy Bickel has a paper about it and kind of consistent with the arguments that you've made, but not aware of anyone that's actually conducted a study to do that.
Yeah, it's just really made me think about, you know, we use these measures every day to draw conclusions, but is there something underlying that we're just been ignoring for years?
Yeah, I agree.
Well, awesome. We're at time, but thank you everyone for all your comments and questions for Gus, and thank you so much, Gus. It was a great presentation. Very good representation of all the great data we're getting from the SORT study, so we appreciate that.
Yeah.
For all the strong work for everyone on the call who's been working on that study. Great. Well, thank you so much. And like I said at the beginning, reach out to Lilia if you have any questions or anything else, and we'll see everyone next month. Have a good night, everyone.
Bye, everyone. Thanks.
Thanks, guys.